You as a third year medical school at this point of time, although it is a bit late, you should do what doctors do. It is purely common sense, isn't it? This is what doctors do. They collect data, they ask questions and collect information. They think about it, they analyze the data, they discuss with themselves and with their colleagues, they integrate, and then they share. These are the activities that you will do all your lives. And why should you stop at collecting data and not doing the other activities? All these steps that doctors do, they lead to understanding of the problem, and understanding is the name of the game. It is not memorizing. We were talking about common sense, but unfortunately, common sense is not so common. Why bother studying development of the gastrointestinal tract? Because the gastrointestinal tract from its beginning, like in this phase of a baby, where you can see there is stoppage of fusion of the upper lips. Now, down to the anal canal, things usually develop very well and reach 100% of development. Sometimes, as embryology is made of steps of developing organ, this development can stop at any moment, either in the beginning, halfway, or near the end. This is a case of maldevelopment, not only of the upper lip, but involving the hard palate as well. Here is yet another example of problems of developing gastrointestinal tract. As we can see here, that this is the beginning of the esophagus, and the trachea is going to take origin from the esophagus, while the upper end has stopped after giving the origin to the trachea, but the lower part of the esophagus is now connected to the trachea, and there is a variety of malformations of the very beginning of the esophagus. Now, the newly born baby is going to suffer from these congenital abnormalities, so we have to understand what is going on. If you look at the image to the right, it is a chest x-ray of a patient in which we can see the shadow of the heart, but to the outside of the shadow of the heart, there is a larger shadow with fluid level in that shadow, and that is because the stomach has herniated into the thorax. The figure to the left is a diagram showing that the stomach, because of short esophagus, the stomach is going to be herniated into the thorax. Here's an image to your lower left, where you can see a newly born baby with distended abdomen, while when you look to the right, this is a barium of the same baby, where we can see between the two arrows that there is a thin, long pyloric canal. This is because of congenital hypertrophy of the pyloric sphincter. We will know in the next few slides that the gastrointestinal tube is formed then it's going to be filled with cells. That is meaning it is blocked, but there is recanalization. Sometimes this recanalization is going to stop in one segment, causing block of the tube. On the left, you can see that this is a barium meal, and the barium could not propagate, could not go to the next segments of the intestinal tract. Here is a post-mortem photograph of the liver, where one can see that the gallbladder, the cystic duct, and the next ducts of the biliary system are hugely dilated, green structures. That is because the canal of for example, common bile duct has not been canalized, so it is blocked. There is a variety of blockage of the biliary passages at different stages and in different canals and ducts. These are congenital, and once the baby is born, then he is going to be jaundiced. Here's an image of a jaundiced baby lying in hospital for treatment of what is called congenital atresia of the biliary passages. Atresia means congenital blockage. There is a case called annular pancreas. The pancreas is made of two buds, a posterior one and an anterior one. The anterior is going to rotate clockwise to meet the posterior one, and sometimes this process stops at one stage, and the pancreas is going to constrict the duodenum, and this is called annular pancreas. Here is a case of what is called volvulus of the intestine. If the intestine, when it develops, it goes to the outside of the abdominal cavity because it does not fit in a small cavity, but then it returns. If it doesn't return in a normal way, things will go wrong, and this is one of the cases of bad return of the intestine into the abdominal cavity. Here's an image of a baby in which as the small intestine elongates, it goes out of the abdominal cavity into the umbilical cord, but then the cavity will get bigger and the intestine should come down into the abdominal cavity. Now, this incident did not happen, therefore this baby is born with a defect in the anterior abdominal wall, and the herniated small intestine is still existing. This is a similar case. Therefore, when we study the development of the gastrointestinal tract, there is a stage of small intestine going out into the umbilical cord, and then it is going to return back to be rearranged in normal position. This process stopped and the intestine did not get in. Here is another example of a diverticulum. You see, the small intestine is a long tube and should not have pockets or diverticula, but here a diverticula developed into a ligament that is attaching the small intestine to the umbilicus. This should be obliterated. Sometimes it stops and does not obliterate. Here is a similar case. If you look to your left, you can see that there is a diverticulum coming from the anti-mesenteric border of the small intestine, and the figure on the right, as a barium follow through, you can see that the arrow is pointing at a diverticulum of the small intestine. Here is a case of a newly born baby with distended abdomen, and when a barium study was done, the intestine went into the abdominal cavity, but it did not rotate well. Therefore, there are problems in the intestine of this young baby. Yet another example of malformations of the intestine, and here, if you look to your upper right, you can see that the circle is a lumen of the intestine. It is obliterated, then vacuoles develop, and a lumen is complete. Sometimes the circle or the vacuoles are going to produce two canals, and therefore this is going to be duplication of that part of the intestine. And if you look down to the right, especially the one on the left, you can see that the intestine is duplicated. There are two intestinal canals. The figure to your left, it shows that there is a duplication of a small segment of the small intestine. This is a case of imperforate anus. Normally the rectum ends at the anal canal, and the anal canal opens to the outside. Here, this process of opening to the outside has failed. Therefore, the lower end of the gastrointestinal tract is blocked, and it has to be repaired. What is the starting point of the development of the gastrointestinal tract? This is the starting point. It is the trilaminar embryonic disc. Here is the disc which is going to develop into the human embryo, the human body, and there is a cavity above it, is the amniotic cavity filled with nutrients, and below the disc there is the first yolk sac cavity, and we can see that the trilaminar disc is made of an ectoderm, the blue layer, the red layer is the mesoderm, and the yellow layer is the endoderm. And here is the endoderm in the embryonic disc. This endoderm also lines the yolk sac. And here is the middle part of the embryonic disc. Here is a transverse section at day 20, and showing little development of the ectoderm trying to form the neural tube, and the superior cavity is the amniotic cavity, and the lower cavity is the yolk sac. If you look at the star of the black color present in the top of the yolk sac, this is an important area where it is going to face some development. In day 21, there will be folding of the embryo in both directions, anteroposterior and transverse, and this folding is going to affect the yolk sac. There is going to be a constriction of the yolk sac, and the upper part of the yolk sac above the constriction is going to be involved in the embryo, and this is going to be the tube of the gastrointestinal tract. while the part below the constriction is going to be outside the human embryo, and it is going to be called the extra embryonic coelom, and the connection, the constricted part, is going to be called the vitelline duct. If we look at this area of constriction, this is an important point because it is the point of separation between what is going to be inside the embryo and what is going to be outside the embryo. At the figure of the upper right, you can see that this constriction of the yolk sac is an important event, and if you look lower down, you can see that the tube has formed in the anterior part, and in the middle part or the middle gut there is still the vitelline duct connecting the middle part of the gastrointestinal tract to the extra embryonic coelom, and this is the tail end of the embryo containing the posterior part of the gastrointestinal tract, which is called the hind gut. In day 23, this is what we are going to see. First of all, we are going to see the dorsal mesentery, which is made of mesoderm, suspending the gut tube, which is made of the lining epithelium coming from the endoderm of the yolk sac and surrounded by the red area, which is a mesoderm, which will give rise to connective tissue and the muscular layers of the tube. Let's write some notes after having heard the story of the very early beginning. So the starting point is in the 4th week, and the flat embryonic disc is going to have two folding processes, and the result of folding is that the dorsal part of the yolk sac is pinched off because of the folding, and it is pinched off the yolk sac, and it is going to form the tubular gut. The result of the folding of the embryo is pinching off part of the yolk sac, and a tube is formed, and the wall is made of an endoderm on the inside and a mesoderm on the outside. Now, what is next? Next is this tube is going to be filled with cells again, so it is having no lumen. After a short period, vacuoles will appear in the lumen, and these vacuoles will unite together to form a canal again. Sometimes this vacuolation is not going to unite properly, and it is going to form stenosis. Sometimes it forms duplication, and sometimes produces blockage that is called atresia. So initially the gut tube is a hollow structure. Now in week 6 the endoderm is going to proliferate until it fills the cavity and it completely occludes the lumen. Now in week 7 and 8 vacuoles appear, and these vacuoles will unite with each other until they recanalize the tube again. what is this diagram showing? First of all, if you look to your left, you can see the head part folded and looks downward, and then we have this line. To the left of this line, where you can find the mouth and the pharynx, this part of the gastrointestinal tract develops from the branchial arches that will give rise to the head and neck, and it is not part of the process of tube formation we have just discussed. So at the beginning of the esophagus down to the point of entry of the common bile duct into the descending part of the duodenum, this part is called the foregut, and this foregut is going to be supplied by the celiac trunk and its branches. Now, from this point of entry of the common bile duct down to the junction between the right 2/3 of the mesocolon and the left third of the transverse colon, this area is called the midgut, and it is supplied by superior mesenteric artery. From the lateral part of the left part of the transverse colon down to the anal canal, it is called hindgut. This is a scanning electron microscope of the embryo at that stage. There are two images in this slide. The one you see to your right is the folded embryo, and if you look to its left, you can see the head part, and the red structure is the heart. Then inside this folding, you can see here on the image on the left, you can see the area which is forming the membrane. It's called the stomodium, which is the beginning of the mouth. Now, in the structure to your right, you can see the stomodium, which is the membrane blocking the beginning of the mouth, and it is breaking at this moment to form the opening of the mouth. The figure on your left, it is also showing the stomodium, and this is the area of the branchial arches development, and you can see there is an arch 1 forming the maxillary and the mandibular part, and then 2, 3, and 4. This is a diagram of the embryo, where you can see first that this is the brain vesicle and the part forming the head. Then there is an opening here, which is the beginning of the mouth, while the buccopharyngeal membrane has been disappeared, and here is the heart just under the mouth. And inferior to the heart, or to your right, is a very important structure which is thick, made of mesoderm, and it separates the thorax from the abdomen, and the heart sits on it. The liver and a few other structures will develop into this septum transversum. Septum transversum is going to give rise also to the diaphragm, but at this stage it is thick mass of mesoderm. This is a diagram of cross-section of the developing embryo, and it is in the thoracic region. What do we see here? We can see that this is one pleural cavity, and this is the other pleural cavity, and between them the future mediastinum, but at this point it is made by a membrane called pleuroperitoneal membrane. Then in the midline we have the developing esophagus. Now the area anterior to the esophagus is formed by septum transversum. What is going to happen in the upper end of the esophagus? Now in this area there will be a bud which is going to develop into the lower respiratory system, and it is called the respiratory bud. This bud is going at first to be connected to the esophagus, and it goes down and starts to develop the primary bronchi, and the two lumens of the esophagus and the trachea, normally they should be separated totally, and things will go their way on either side. Here is a diagram showing that the tracheal bud or the respiratory diverticulum is going to develop from the esophagus, and then the process of separation is going to take place by forming the tracheo-esophageal septum, and the two systems now are separated totally, and this is going to happen at the end of week 4. Here is checking what we have learned. What's going to happen to the upper part of the esophagus? That's the cephalic end. It is going to be partitioned by what? By a membrane called tracheo-esophageal septum. The esophagus develops from what? It is the beginning of the foregut, and it is immediately beyond the pharynx. To start with, the esophagus is short, but it is going to lengthen rapidly. If it stays short, then the stomach is going to develop in the thorax, and this lengthening is due to the descent of the heart and the growth of the lungs, reaching in its normal position at the end of week 7. This is a reminder of septum transversum, and this is a very important structure, and as we go across section along the black line, and we can see the two pleural cavities, and this, the septum transversum is going to form the anterior part of a cross section of the thoracic part of the body, where we can see the esophagus. We are in the same area where we can see that the vertebra is posterior and the opposite side is anterior, and we can see that this is the tube of the esophagus, having pleural cavities on both sides, and anteriorly is the septum transversum. This is a diagram showing the septum transversum, which is inferior to the heart, and it is anterior to the esophagus and the stomach. And if you look at the image to the right, we can see that the septum transversum extends from the posterior wall, then reaching the anterior wall, and the liver is going to develop into the septum transversum. Let us see what this image is telling us. First of all, this is the septum transversum where the liver is going to develop. Septum transversum is going to give the liver the blood vessels and the framework of connective tissue. Then we have the dorsal mesentery of the stomach. This is developing from the mesoderm from the beginning of the formation of the tube, and this is C, the ventral mesentery, and we should stop here and emphasize the fact that the gastrointestinal tube has dorsal mesentery along its length, but the ventral mesentery, that is the mesentery, two folds of peritoneum connecting any structure to the anterior abdominal wall, is only, and you underline only, present where the septum transversum is existing. You see the yellow star is representing the septum transversum, where you can see that the anterior part to the liver is the ventral mesentery, and in the adult we see it as the falciform ligament. Now the liver, as we can see here, the septum transversum will give the liver blood vessels and connective tissue, while the hepatocytes, they develop from the lining of the duodenum as it comes and forms the common bile duct, then the hepatic ducts, and then enter the septum transversum to produce the liver. The liver has two components, one from the septum transversum and the other is from the lining epithelium of the duodenum. Let's write down some of the notes. Now, here is septum transversum forming the anterior part of the part of the foregut, and then it is completed posteriorly by the pleuroperitoneal membrane, and the esophagus and the stomach are suspended by the dorsal mesentery. Now the septum transversum grows from the anterior body wall to meet the gut tube, plus two pleuroperitoneal membrane. They grow from the posterior body wall to meet the septum transversum, and that is a process which is going to close off the abdominal cavity from the thoracic cavity. When we say closure of the area between thoracic cavity and abdominal cavity, we mean the diaphragm. So anteriorly, and the central tendon of the diaphragm is formed by septum transversum, and then posterior part is formed by the pleuroperitoneal membrane. Now the esophagus does not have a dorsal mesentery, because this dorsal mesentery came down and produced the middle part of the posterior part of the diaphragm. Writing some notes about this process. Later, the septum transversum, which was thick, now it is becoming thin, and when it does that, it forms the central tendon of the diaphragm, and the pleuroperitoneal membrane will become covered by muscles from the abdominal wall and forms the muscular part of the diaphragm. To check our understanding, we need to remind ourselves of what are the parts in the foregut. Here is the area of the subject we are talking about, and this is the line separating the foregut from the midgut, which is just distal to budding of the common bile duct from the duodenum. And this is the dorsal mesentery of the last part of the esophagus and the stomach. And here is the dilated part of the tube, which is the stomach, and this is part of septum transversum, which is going to form the lesser omentum, and here is the liver, developed from two components, and the part of the septum transversum from the anterior abdominal wall to the liver is the ventral mesentery, which is going to form the falciform ligament. In this figure to the left, one can see that the tube is going to dilate, forming the stomach, and the stomach has in front of it septum transversum, therefore it has a ventral mesentery as well as a dorsal mesentery. This dilated part is not going to stay uniformly dilated, but the dorsal part is going to grow much faster than the anterior part, and therefore it becomes very much dilated. Now this stomach is going to rotate clockwise. Therefore, what was posterior, now it is lateral, and what was anterior, now it's medial. Therefore, the lesser omentum, which is part of the ventral mesentery, is now medial, and therefore it is going to go in the direction of the liver. Then this is a 90 degrees rotation clockwise. Then the next rotation, and the stomach has two rotations, the next rotation is going to be in this figure, where this black circle represents the anteroposterior axis. Therefore, the stomach is going to rotate again along this axis clockwise. Therefore, the duodenum, which was lying anterior, is going to the right. Here is in this figure, we can see that the stomach has a dorsal and a ventral mesentery. Then when it rotates in this figure, it is going to move towards the right, and then as it moves to the right, it is going to take part of the greater sac and puts it posterior to the stomach. Therefore, this is going to be the lesser sac, or the omental bursa. There is another factor in addition to the rotation, and this factor is the production of vacuoles in the dorsal mesentery. If we look to your far left, you can see that these black spots are the vacuoles, and they are developing on the right side. Then the next figure is that these vacuoles, as they disappear slightly, and here is the number is less than the first, and it is not present on the left, it is present on the right only. Then in the third figure there are fewer vacuoles, and at the far right there are no vacuoles. This process of vacuolation and disappearance of vacuolation helps the stomach to have a shorter border on the right side than of the mesentery than the left side. Therefore it is helping rotation. We are still in the stomach region and in the region of septum transversum. Now this is going to be the stomach, and posteriorly the stomach, the lower part as it joins the duodenum is going to give rise to the dorsal part of the pancreas. Then we have this is the liver, but this is what is going to form the parenchyma or the hepatocytes. And then what is going to happen next? This is what is going to happen next. The liver, as the stomach rotates, the liver is going towards the right, and the pancreas is going a little bit to the left, and the spleen is going to develop between the stomach and the pancreas, the dorsal part of the pancreas. And you know that this double layer of mesentery between the stomach and the spleen is called gastrosplenic ligament, and then this process is going to go further. Now it's time to write some notes. Why does the stomach rotate? Because first of all, structural changes in the dorsal mesentery of the stomach. That is the first of all, the rotation of the stomach 90 degrees along its long axis, plus the vacuole development. And then also the development of the spleen is going to give a hand to the process of rotation. Now, along the longitudinal axis of the stomach, there will be a turn to form the right and the left side. They are displacing the mesogastrium to form the omental bursa and the greater omentum. Now, anteroposterior axis, as we have seen in the images, the pyloric part is going to move up and to the right, and the cardiac part of the stomach at the point of joining of the esophagus is going to move down and to the left. What are the results of the stomach rotation? First of all, the stomach is on the left with the anterior and posterior surfaces. The C-shaped duodenum is going on the right, and the liver is going on the right as well. These movements of the liver and the duodenum is going to create the formation of the lesser sac. Now, what about the greater omentum? The greater omentum is attached to the greater curvature, which was posterior. When it turned 90 degrees clockwise, it became to the left. But when the stomach rotates along its anteroposterior axis, the greater omentum moved from the left and came down to be hanged down to the pelvis. We were mentioning the formation of the lesser sac as the stomach is rotating. And when is this happening? It is happening in week 4 when the small cellular clefts appear in the mesenchyme dorsal to the stomach, and they take place in the dorsal mesogastrium, and they disappear. Therefore, they help the stomach to move clockwise along its long axis. We were talking in this area here about dorsal mesentery, ventral mesentery, transversum, septum, the stomach, and the liver. Now we are going to move to the midgut. The midgut is the part starting from distal to the entry of the common bile duct down to the junction between the right 2/3 of the transverse colon and the lateral 1/3, and the midgut is supplied by the superior mesenteric artery. Here we can see that there is a yellow tube, U-shape structure with the superior mesenteric artery in the mesentery of this loop. Here is what is going to happen to this loop of the midgut. Now we can see that the brown color is that of the abdominal aorta, and we can see the dorsal mesentery coming from the posterior part, and the ventral mesentery, the anterior part of septum transversum, which is colored pink. Now there is the foregut, which is opposite the septum transversum, and then we go to the right and we can see that there is the midgut that is going to begin after the duodenal papilla, and the pink colored area is the septum transversum. That's the midgut, and this is septum transversum. In this figure we can see that there is budding. The dorsal bud is the dorsal pancreatic bud that is going to grow into the dorsal mesentery, and the ventral one is the bud which is called liver bud that is going to give us several structures, and this is the septum transversum. So the liver bud is going to grow into the septum transversum. Then the liver bud is going to grow into the septum transversum and divides into two branches into the septum transversum. There is the liver bud and another bud which is going to form the ventral pancreatic bud. So now we have a dorsal pancreatic bud and a ventral pancreatic bud. Then next is, this is the dorsal pancreatic bud, and this is the liver bud, the beginning of it, and this is going to form the common bile duct. This is the ventral pancreatic duct, and this is the cystic duct. This is the goal. What is next? Next we see that the dorsal pancreatic bud is growing and taking a longer shape, and the common bile duct is still there. This is the common hepatic duct. This is the ventral pancreatic duct, and this is the cystic duct going to the gallbladder. Here is a reminder of the rotation of the stomach and how structures start to get growing, and this is the stomach, and here is what was the dorsal mesentery of the stomach, and as this dorsal mesentery, as the stomach rotates, it is going to create the lesser sac. Is the spleen developing in the dorsal mesentery of the stomach, which was in the midline, and now due to rotation it is on the left. And this star is in the lesser sac, posterior to the stomach, and this is the lesser omentum, which is part of septum transversum going to the liver. Let's see what is next. Here, as the liver gets larger, it is going to reach the inferior vena cava, and the inferior vena cava is going to create a deep impression on the liver. This is the duodenum, and if we look, we can see two pancreatic buds colored green, and this is the ventral pancreatic duct or a bud, and then this is the dorsal pancreatic bud. The ventral pancreatic duct should join the dorsal one by going around the duodenum. If the process stops in the middle, then the duodenum is going to be surrounded with pancreas, and this is called annular pancreas. What is next? What has happened in the previous few slides is that the ventral pancreas rotated, joined the dorsal pancreatic bud, and then the whole process was proceeding, and the proceeding was that they are stuck to the posterior abdominal wall and became retroperitoneal. What do we see here? We see the ventral bud of the pancreas is going to rotate clockwise behind the duodenum and the stomach, and it is going to meet the dorsal pancreatic. Let's write some notes. The ventral mesentery exists only when there is septum transversum, and the part that face the septum transversum is the terminal esophagus, stomach, and upper part of the duodenum, and the growth of the liver later divides the septum transversum into lesser omentum posteriorly connected to the stomach and anteriorly as the falciform ligament. Here is a sagittal section of the developing gastrointestinal tube, and we are going to look into this loop of the small intestine. This is a diagram of the loop of the midgut part of the small intestine. At the top we can see the abdominal aorta giving rise to the superior mesenteric artery, which is the blood supply of the midgut. To the left we can see that there is a loop of small intestine, and this arrow is indicating the proximal or the cephalic limb of the loop. Then to the right, this arrow is indicating the caudal or the distal end of the loop of the midgut. At the apex of the loop, lower down, we can see that this loop is extending into the umbilical cord, reaching the extra embryonic coelom, or what was the yolk sac later on, and there is a connection between the intra-embryonic coelom and the extra-embryonic coelom. This is the vitelline duct. What is happening here? We can see that the cephalic part of the loop, the proximal limb of the loop, has elongated, and this is going to be compared to the other limb, or the distal part of the loop, which is not elongating, but we can see that lower down in the distal part of the loop there is a beginning of a dilatation. This is going to be the beginning of the cecum. What is happening here? What has happened is that there is a rotation of the loop along the axis of the superior mesenteric artery. The proximal loop, which is forming the small intestine, which has elongated, now it is on the right. The distal, or the caudal limb of the loop, was on the right. Now it has changed position to the left, and then if you go down you can see the cecal dilatation, the beginning of the large intestine. It is important that the intestine rotates this way, and the large intestine, represented by the distal part of the loop, must be in front of the proximal part, which should be posterior. Here is a case of non-rotation. Why this is non-rotation? Because the part of the loop which has elongated, it is still on your left, and the distal part of the loop is still on your right, and the distal part is going to form the large intestine. The proximal part is going to form the small intestine. This is a case of reversed rotation. The normal rotation should result in that the large intestine should be in front of the small intestine. Now, in this case, we can see that it is the small intestine that is in front of the large intestine, and the small intestine is to your right, while the large intestine is to your left, and lower down you can see the cecum. This is reversed rotation. It may happen in newly born babies. This is the diagrams we have seen a few slides ago, and we should emphasize that the rotation must bring the large intestine in front of the small intestine. The loop of the midgut is usually connected by the vitelline duct to the extra-embryonic coelom through the umbilical cord. Now, this connection, or the vitelline duct, must be obliterated. Sometimes it does not, and there is a little part proximal to the intestine remains, and this is called Michel's diverticulum. In other instances, near the loop of the intestine and near the abdominal wall, the vitelline duct is obliterated, but it retains a cyst in the middle. This is called enterocyst. The lower image to your right is a case where the vitelline duct is going to persist. That means when the baby is born, the intestinal secretions will be going out through the umbilicus. This is the normal situation where when the distal loop turns around and becomes to your left, that is to the right of the person, and the cecum will be under the liver, which is going to come down. And in an anterior view, the large intestine represented here by the orange tube should be in front of the small intestine. This is happening during the 77th day. It is important here to notice that this view is a lateral view, and the rotation is going to be along the axis of the superior mesenteric artery. Therefore, the orange part with the cecal diverticulum is going to rotate, and instead of being inferior to the proximal limb, now it is to the side of the proximal limb, and this is a 90-degree rotation counterclockwise. Later on, this distal limb of the midgut, which was inferior to the proximal, and in the previous slide we saw it is just in front of the proximal limb. Now it has rotated extra 180 degrees to be just behind the proximal loop. Now, later in the fetal life, now the large intestine is in front of the small intestine in a frontal view. The caudal limb of the midgut loop undergoes very little change except for the development of what? For development of the cecal diverticulum, which is the primordium of the cecum, and of course the appendix. The cranial limb, or the proximal limb of the loop of the small intestine in the midgut, this is going to grow, increase in length and very rapidly, and forms the small intestine. The midgut loop with its two limbs is suspended from the posterior or the dorsal part of the abdominal cavity by a elongated mesentery. Here is something new. The midgut loop elongates to form a ventral U-shaped midgut loop of the intestine. This is going to project into the proximal part of the umbilical cord. Why projecting? Because the abdominal cavity now is still small and this loop is elongated, plus the liver has enlarged rapidly, and there is no space for the intestine to occupy in the abdominal cavity. Now, While this mid-gut loop is in the umbilical cord, it is going to rotate 90 degrees, the rotation we have just talked about, along the axis of the superior mesenteric artery counterclockwise. This rotation, the 90 degrees rotation of the midgut loop, it is going to bring the cranial or the proximal limb of the small intestine, it is going to bring it to the right, and the caudal end or the distal end is going to go and form large intestine going to the left part. Normal rotation should bring the small intestine to the right and the large intestine to the left, with the point of crossing should be anterior to the small. Now, when the abdominal cavity, by the growth of the embryo, is getting large enough, the small intestine will come back to the abdominal cavity. This is a process of retraction that is coming from the protrusion into the umbilical cord to the abdominal cavity, and this occurs in week 10. The first part of the loop of the midgut to enter is the proximal jejunum, and the last is the cecal bud, which is initially is present below the liver because it rotates 180 degrees. It then descends, forming a diverticulum that becomes the vermiform appendix. What is next? In this diagram showing the development of the intestinal loop as it comes back home in the abdomen, and if we draw a midline in the middle, we can see that on the right side there most of the small intestine is lying, and if we look at the left side, then it is the large intestine. Now you are oriented that this is a diagram of a cross-section of the abdomen, and the vertebra is posterior, and the other part, the other pole, is anterior, and the yellow tube is the small intestine, and this is the large intestine. See what is going to happen to the large intestine. First, it is going to stick to the posterior abdominal wall. Then it is going to be retroperitoneal. This is a diagram of a sagittal section through the abdomen, showing the loops of the intestine, the liver, the dorsal aorta, and follow what is going to happen here to the large intestine. This is the large intestine. It is going to be stuck to the posterior leaflet of the greater omentum, and then is going to be part of the posterior leaflet of the omentum. Now follow what is going to happen inside this black oval shape, which is the area of the greater omentum, as two layers come down and then they turn and go up. They fuse together, and the large intestine, which is the transverse colon, is going to be incorporated into it. This is a sagittal view of the uh, embryo, and if we look towards the tail end, we can find the distal part of the gastrointestinal tube uh, formed by the hind gut. Then we can see that this is a structure that is called the allantois. We have met this structure earlier, while it is an extension of the yolk sac into the umbilical cord, and it is going to form part of the urinary system. These two structures, the hindgut and the allantois, they are going to meet in a cavity which is called the cloaca. Let's look at the figure on the left. First of all, we can see that this is the last end of the hindgut, and the anterior part we can see the allantois, which is going to develop into the urinary bladder. Now, in the angle between them, there is a mass of mesoderm called the urorectal septum. This septum is going to come down. The hindgut and the allantois, they meet in an area called the cloaca. The cloaca is a common cavity for the hindgut and for the developing urinary bladder, and it is closed at this stage by the cloacal membrane. Then we go to the right figure, where we can see that the urorectal septum grew and went between the two structures, separating the urogenital or sinus or the future urinary bladder and the rectum, and each of these structures is going to have its own opening instead of a common opening at an earlier stage of development. This is the last end of the gastrointestinal tube. The yellow part is the last end of the rectum, which is part of the hindgut, and then we have a new structure which is called the proctodium. The proctodium is an ectoderm thickening in the area where the hindgut should open to the outside, and it is made of ectoderm cells. And when they meet in the pectinate line. This pectinate line, or the white line, is the point of joint between the last part of the hindgut, the rectum, and the anal canal. This is a diagram showing the meeting point of the last end of the hindgut with the anal canal. Now, the hindgut lining is made of endoderm, while the anal canal, or the proctodium, is coming from the skin as a thickening, and then it goes in and it is made of ectoderm. The point of meeting of the endoderm of the last part of the rectum with the ectoderm of the anal canal is a white line, and it is called the pectinate line. This is a drawing representing a coronal section of the part of the face, where we can see here is the tongue, so the space around it is the mouth cavity. And if we go to the lateral boundary of the mouth, then we can see the cheeks. And in this case, the mucosa or the mucous membrane of the cheeks uh, is going to give rise to a bud that is going to grow laterally and will form the parotid duct beginning. And then the duct, as it comes and goes to its final destination, it is going to form the parotid gland. And so is the case on the other side, and it is the same story of developing the submandibular gland. So these glands, they originate from the lining of the mouth, and the ducts are formed first, and as they go towards their final destination, they start forming the secretory part of these salivary glands.